Hi there, my valued and highly treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I'm a clinical pharmacist by training and by profession, and I'm the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I kindly urge you to sit back and spare me part of your precious time to share some tips with you. So welcome to part 27 of our pharmacotherapy MCQ series. So question 1 reads, which of the agents listed below increases the conversion of plasminogen to plasmin and is dosed as a start dose? That is to say, IV bolus over 10 seconds for the treatment of STEMI within 12 hours of onset. Its symptoms, assuming there is no contraindication. Is it Reteplase, Alteplase, Tenecteplase, or Streptokinase? I'll give you 10 seconds to choose the correct answer from that list of 4. So in my opinion, Tenecteplase it is. All the listed items are thrombolytics that can be used in the treatment of STEMI within 12 hours of the onset of the symptoms, assuming no contraindications exist. But only Tenecteplase can be administered as a weight-based IV bolus over 5 to 10 seconds. Remember, the question was very specific about timing. The longer half-life of Tenecteplase is the reason for this easier dosing regimen. Reteplase is given as an IV bolus of 10 units over 2 minutes, and that is repeated after 30 minutes. Alteplase is administered as a weight-based dosing plan via IV infusion over 3 hours as per the manufacturer recommendations, which can also be administered via an accelerated regimen that is more popular in many of our institutions. It is also approved for STEMI within 12 hours of the onset of the symptoms for acute ischemic stroke and pulmonary embolism with hemodynamic instability. So those are just additional by the ways, but the conditions listed in the question suit Tenecteplase the most. Let's move to the next question, which reads, a 67-year-old male patient presents to the clinic. He has a past medical history of type 2 diabetes mellitus, hypothyroidism, benign prostatic hypertrophy. He informs your clinical team that his other doctor changed one of his medications, but he doesn't remember which one it was. He now feels dizzy and lightheaded upon standing, which has resulted in a fall on 2 different occasions when getting out of bed in the past 7 days. So my question to you is, which of the drugs listed below do you suspect is responsible for these symptoms? Is it aspirin, clopidogrel, terazosin, or synthroid? I'll give you 10 seconds to choose the correct answer. So in my opinion, terazosin it is. Terazosin, also known as Hydrin, is a non-selective alpha-1 blocker that is used in the management of both BPH and hypertension, which is commonly associated with orthostatic hypotension, dizziness, and flushing, especially in the geriatric population. Now, just as a by the way, alfuzosin and tamsulosin are more specific inhibitors of alpha-1D receptors, to be specific, that are located in the urethra and the bladder neck, and they are used in the management of BPH specifically. And they have lower likelihood of causing hypotension, dizziness, and orthostasis that are notorious for increasing the risk of fall. That's just as by the way. Now, the other three drugs, aspirin, clopidogrel, and synthroid, don't have this symptom, nor do they have this possibilities of causing this according to their mechanisms of action. So I'll settle for C as my correct answer. Let's move to the next question, which reads, LMA is a 61-year-old male patient who has been in atrial fibrillation for the past 10 days. He has a past medical history of type 2 diabetes mellitus, and he is hypertensive. An echo was done 30 days ago that showed a normal ejection fraction of 60%, and on the echo we were able to tell he has no left ventricular hypertrophy, neither does he have ventricular dysfunction. So his chief complaint happens to be occasional palpitations while actively walking with his dog or doing work on the yard. That is to say, while involved in some form of activity. Now, his vitals include a BP of 141 systolic, 85 diastolic, with a heart rate of 120, pretty high. He's currently taking 10 milligrams of lisinopril once daily orally, 5 milligrams of glipizide once daily orally for his diabetes mellitus, and he is electrically cardioverted to normal sinus rhythm. The clinical team decides to initiate an oral antiarrhythmic agent to maintain normal sinus rhythm. So my question to you is, which of the agents listed below isn't recommended to maintain a normal sinus rhythm in our friend LMA? Is it Sotalol, Flecainide, Propafenone, or Ibutilide? I'll give you 10 seconds to choose the correct answer. So Ibutilide, in my opinion, it is. And this happens to be a class 3 antiarrhythmic, which is used for acute termination or cardiovascular of atrial fibrillation, and not for the maintenance of treatment of atrial fibrillation. Now, Flecainide is a class 1C antiarrhythmic, Sotalol is a class 2 and 3 antiarrhythmic agent, and Propafenone is a class 1C agent, and they can all be used to maintain normal sinus rhythm in patients with no or with minimal heart disease for AFib. So D is the correct answer. It is the odd figure out there. It's the one that cannot be used. Let's move to the next slide, which reads, a 65-year-old white male presents to the hospital with a past medical history of hyperlipidemia, type 2 diabetes mellitus, congestive heart failure. He belongs to New York Heart Association, class 3. His last heart failure hospitalization was 9 months ago. And the echo reveals a left ventricular ejection fraction of 32%, pretty low. He's currently taking 81 milligrams of aspirin once daily orally, and he takes a combination of valsartan and sacubitril, 103/97 milligrams twice daily orally, and 10 milligrams of bisoprolol once a day. He's also on spironolactone, 25 milligrams once daily, and 40 milligrams of furosemide orally once daily. His vitals today include a blood pressure of 129 systolic, 80 diastolic, a heart rate of 78. His chief complaint today is shortness of breath when walking to his mailbox or cleaning up around his apartment. He doesn't have any peripheral edema. His labs are within normal limits, and recent ECG showed that he is currently in normal sinus rhythm. So basing on the above, my question to you is, which of the following would be the best therapeutic option for our patient? Would it be increasing the spironolactone dose to 50 milligrams twice daily orally? Or is it true that no changes are indicated at the moment? Or would you discontinue bisoprolol and initiate ivabradine? Or would you decrease the furosemide dose to 20 milligrams once daily? I'll give you 10 seconds to choose the correct answer. So in my opinion, the correct answer is C. I would opt to discontinue bisoprolol and initiate ivabradine. According to the ACC, the AHA, and the Heart Failure Society of America heart failure guidelines, ivabradine can be beneficial to reduce heart failure hospitalizations in patients with symptomatic, in other words, New York Heart Association class 2 to 3 heart failure, or a stable chronic HFrEF with a left ventricular ejection fraction of equal to or less than 35%, who are receiving guideline-directed management, including beta blockers at the maximum tolerated doses, who are also in sinus rhythm with a heart rate of 70 beats per minute or greater. Now, answer B is incorrect. This gentleman would benefit from additional medication changes to improve his quality of life, since he is symptomatic with daily activities. Now, increasing the spironolactone dose by doubling it to 50 milligrams twice daily would not provide much additional benefit, in my opinion, and is also greater than the usual maintenance dose of 25 BD for this particular indication. And decreasing the furosemide dose by halving it to 20 milligrams isn't warranted, in my opinion, since this patient does not have any symptoms of dehydration, and his labs, as we were told, are reportedly within normal limits. It's also important to initiate beta blockers and to titrate them to the target dose or to the maximum tolerated dose. Or if we have a contraindication to beta blockers, and there might be need to assess the resting heart rate for consideration of ivabradine initiation. Ivabradine is a drug that selectively inhibits the hyperpolarization activated cyclic nucleotide gated Fanny currents in the SA node. It's quite a unique mechanism of action, and the end result is they provide heart rate reduction through this mechanism, and it is contraindicated in acute decompensated heart failure. That is heart failure where the BP is systolic less than 90, diastolic less than 50 millimeters of mercury, with a resting heart rate of less than 60, or where there is SA block, or with concomitant use of strong CYP3A4 inhibitors. Just as a by the way, let's move to the next question, please, which reads, ANT is a 51-year-old male patient, and he is at the A&E with the supraventricular tachycardia upon further examination and analysis of his ECG. It is determined that he has antidromic Wolff-Parkinson-White. He doesn't have any other past medical history and doesn't take any other medication. So how best would you intervene in ANT's case now that you know he has WPW? Would you administer 5 milligrams of Metoprolol via IV bolus? Would you administer Esmolol 500 micrograms via IV bolus? Or would you administer 0.35 milligrams per kilo of diltiazem over 30 minutes? Or would you administer 17 milligrams per kilo of procainamide IV over 30 minutes? I'll give you 10 seconds to choose the correct answer. So I would settle for D, procainamide at a dose of 15 milligrams per kilo, administered via IV infusion over 30 minutes. Antidromic WPW occurs when the electric circuit travels from the SA node through the accessory pathway first, then up the Purkinje fibers and through the AV node, all in a retrograde, that is to say the opposite direction than the orthodromic tachycardia. It is necessary to treat with agents that selectively target the accessory pathway and avoid agents that block the AV node for obvious reasons. Now, procainamide is the drug of choice and should be administered at a loading dose of 17 milligrams per kilo IV at a rate of 20 to 50 milligrams per minute via IV infusion until the arrhythmia is suppressed. So you have to observe the patient very carefully and until hypotension ensues and the QRS is prolonged by 50%. So you need to observe all those parameters. The other agents listed delay conduction through the AV node and should be avoided at all costs in this patient. Now, long-term procainamide use has its downside. It's associated with the development of anti-nuclear antibodies and drug-induced lupus erythematous-like symptoms. And that is a black box warning when you read the literature carefully. The active metabolite of procainamide, the N-acetyl procainamide, which we also call NAPA, may accumulate in patients with renal impairment. So you need to know your patient well before you settle for procainamide and monitor closely for those adverse drug reactions. Just as a by the way, let's move to the next question, which reads, which class 3 antiarrhythmic drug used in the management of atrial and ventricular arrhythmias listed below is mainly renally cleared and known to require renal dosing? Is it diltiazem, procainamide, atenolol, or sotalol? I'll give you 10 seconds to choose the correct answer. Sotalol it is. Now this is the only listed agent that is a class 3 antiarrhythmic agent which is also renally cleared and is known to require renal dose adjustments once the creatinine clearance reaches or hits a value of below 60 milliliters per minute. Now failure to do so can increase the risk of bradycardia and or QT interval prolongation, so you have to be very cautious. Now, atenolol is a selective beta-1 blocker which is classified as a class 2 arrhythmic agent, which also primarily renally cleared. But the class there differs. It's 2 and not 3 according to the question. And diltiazem is a non-dihydropyridine calcium channel blocker which is classified as a class 4 this time round antiarrhythmic agent due to its inhibition of the AV nodal conduction in the heart. It's primarily metabolized in the liver and may cause drug-drug interactions due to its CYP3A4 inhibition. So be cautious when co-administering it with drugs that go through that same metabolic pathway. Procainamide is a class 1, not 3, class or 2, class 1 antiarrhythmic agent that can also cause QT interval prolongation and needs to be renally dose adjusted once the creatinine clearance hits the below 50 ml per minute mark. Sotalol is a class 2 and 3 antiarrhythmic agent which also requires renal dose adjustment in renal impairment to reduce the risks of development of bradycardia and or QT interval prolongation. The beta blocking properties that it has gives it a class 2 classification and results in the slowing of the heart rate. Just as a by the way, let's move to the next question. So BJM is a 61-year-old man who has been AFib for the last 10 days. He has a past medical history of hypertension and type 2 diabetes mellitus. This is his first episode of AFib, and his ECG from 30 days ago shows a normal ejection fraction of around 60%, no left ventricular hypertrophy or ventricular dysfunction. His chief complaints are occasional palpitations which occur mostly while he is active. His vitals include a blood pressure of systolic 141, diastolic 86, with a heart rate of 120. It's revving pretty fast. He currently takes 10 milligrams of lisinopril once daily and 5 milligrams of glipizide. Which of the statements below is correct regarding BJM's use of rate control? Is it BJM's goal heart rate should be 40 to 50 beats per minute at rest? Or is it BMJ should be started on Metoprolol? Or should BMJ be started on Amlodipine? Or finally, should BMJ be started on oral digoxin? I'll give you 10 seconds to choose the correct answer. So in my opinion, B is the correct answer. He should be started on Metoprolol. Now, only Metoprolol and digoxin from the 4 options listed above can affect pulse or heart rate. Digoxin has a greater impact on the resting heart rate and will not offer sufficient rate control during physical activity. So it wouldn't suit this gentleman well. Metoprolol, on the other hand, will affect the heart rate both at rest and with physical activity, so it would be a good choice. Now, choice A demonstrates bradycardia which is less than 60 beats per minute, and that's too low for a goal, so I would not opt for it. And amlodipine in option C doesn't affect the heart rate. It doesn't antagonize the voltage-gated calcium channel in the nodal cells and doesn't have a dromotropic effect like the other calcium channel blockers D.T.M and verapamil do. So I would not settle for it either, and we've already seen why digoxin is not a good option. So let's go to the next question, which reads: a patient whose blood pressure is poorly controlled presents to the clinic today the past medical history of hypertension, systolic heart failure, is in stage B with an ejection fraction of 35%. He has a systolic blood pressure of 153, diastolic 97, You let him rest a bit and repeat the same readings, and this time round it's 148 systolic, 92 diastolic with a heart rate of 70. So he was pretty anxious when he took the first reading. Maybe that's why the values were slightly elevated. His blood pressure goal is set to be less than 120/80. His labs are within normal limits, and his current meds include lisinopril at a dose of 40 milligrams once daily, carvedilol at a dose of 25 milligrams twice daily orally, and is also on hydrochlorothiazide at a dose of 25 milligrams orally once a day. You decide to initiate a calcium channel blocker for further blood pressure reduction. So my question to you is, which statement below regarding calcium channel blockers is true? Is it diltiazem induces positive inotropic and chronotropic effects? Or is it amlodipine has a greater risk of bradycardia compared to diltiazem? Or is it true that amlodipine is contraindicated in systolic heart failure patients? Or is it true that both amlodipine and diltiazem can cause constipation and GERD symptoms? I'll give you 10 seconds to choose the correct answer. So in my opinion, D is the correct answer. Both amlodipine and diltiazem can cause constipation and GERD symptoms. Now, dihydropyridine calcium channel blockers have greater vascular selectivity than the non-dihydropyridine calcium channel blockers, and therefore have minimal cardiac effects. That is, minimal effects on the heart rate and contractility. Now, the non-dihydropyridine calcium channel blockers have greater SA and AV nodal and myocardial activity, producing negative chronotropic activity. That is, they decrease the heart rate, and they also have inotropic activity. They decrease contractility. Now, unfortunately, they don't protect against remodeling. Hence, they are generally contraindicated in systolic heart failure. Both classes of the calcium channel blockers, both the dihydropyridine and the dihydropyridine, can cause constipation and GERD symptoms due to the fact that the calcium channel blockade in the GIT leads to a decrease in peristalsis and in the lowering of the esophageal sphincter tone, respectively. That can cause worsening of the GERD when the sphincter muscles are loosened, and constipation. Just as a by the way, let's move to the next question, which reads: a 64-year-old female patient with a past medical history of hypertension and tobacco abuse is undergoing treatment for an NSTEMI and is being prepared for discharge. Now, my question to you is, if no contraindications exist, which of the drugs listed below should be initiated in her case as secondary prevention for her cardiovascular disease, especially myocardial infarction? Would it be Metoprolol, Aspirin plus Dipyridamol, Eliquis, or Simvastatin? I'll give you 10 seconds to choose the correct answer. In my opinion, two options would work just fine. I would consider both Metoprolol and Simvastatin, and they have both shown benefit post-MI, and unless there is a contraindication, they should be given consideration in all post-MI patients. Aspirin plus Dipyridamol, which is option B, is indicated for secondary stroke prevention, not post-MI. So this would be the wrong indication for it. Pixiban, which is also called Eliquis, is a factor 10A inhibitor. It's a direct oral anticoagulant, a DOAC, which is taken twice daily for the prevention of stroke in non-valvular atrial fibrillation, and it's also used in VTE prevention and treatment. So this would be the wrong indication for Eliquis, apixaban. You can use it better elsewhere, just as a by the way. Let's move to the next question. HWS has been initiated on clonidine patches for the treatment of hypertension. What would be your crucial counseling point regarding changing of the patches, the clonidine patches, as you manage hypertension in HWS? Would you advise this patient to change the patches every 3 days, on a daily basis, once weekly? Or would you advise the patient to remove the patches after 12 hours of use to allow for a 12-hour medication-free period to avoid tolerance to clonidine? I'll give you 10 seconds to choose the correct answer. So I'd advise the patient to change the patch once weekly, to put one patch in position and let it stay on the skin for 7 good days before switching and administering a fresh one. Now the clonidine patch should be worn for 7 days and changed once weekly for purposes of improving adherence or compliance. The initial starting dose is usually around 1 milligram per 24-hour patch, which is gradually increased, 0.1, not 1, 0.1 milligram per 24-hour patch, which is gradually increased by 0.1 milligram every 1 to 2 weeks, up to or no more than 0.6 milligram per 24-hour patch. Now, exceeding the 0.6 milligram per 24-hour dosing doesn't provide relevant improvement in clinical efficacy. And I would just like to remind you that if you are switching from oral tablets of clonidine to the patches, there should be at least 1 to 2 days of overlap, since it will take the transdermal patches that long, 1 to 2 days, to provide appropriate serum concentrations of the active ingredient. The other options listed above apply to different medications. For example, the nitroglycerin patches should be changed after every 12 hours, the nicotine patches after 24, and the fentanyl patches after 72 hours, just for your information. Let's move to the next question. WWW is a 57-year-old Hispanic male patient admitted with AFib, which has been going on for the last 11 days. He is in decompensated heart failure with a past medical history of type 2 diabetes and heart failure. And he tells you this is his first episode of AFib. The current echo shows an ejection fraction of 30 with a left ventricular hypertrophy. His chief complaint is occasional palpitations, shortness of breath, and fatigue. He currently has a systolic blood pressure of 141, diastolic 86, and a heart rate of 121. He takes 50 milligrams of metoprolol succinate once a day, 10 milligrams of lisinopril once daily, and 5 milligrams of lisinopril glipizide, once a day. So my question to you is, which of the antiarrhythmic agents listed below would you recommend for WWW to maintain normal sinus rhythm? Would the choice be propafenone, amiodarone, sotalol, or dronedarone? I'll give you 10 seconds to choose the correct answer. So amiodarone it would be. Either amiodarone or catheter ablation are recommended to maintain normal sinus rhythm in atrial fibrillation patients with heart failure. Now, Sotalol, which is also called Reteplase, can worsen heart failure. I wouldn't go there. And then Propafenone is only recommended in patients with no or minimal heart disease or hypertension. And then Dronedarone isn't recommended in symptomatic heart failure patients at all, especially those with recent decompensated cases that require hospitalizations or that belong to NYHA class 4, just for your information. So amiodarone would be our best bet in this particular question. Let's move to the next slide. ASG is a 69-year-old white man who was initiated on ivabradine procorolan for the treatment of his chronic heart failure, just to reduce hospitalizations. His last ejection fraction, according to the echo when it was done last, was approximately 25%. My question to you is, which adverse drug reactions would you monitor Mr. ASG4 as you initiate ivabradine procorolan? Would it be a cough, AFib, hypotension, or increased heart rate? I'll give you 10 seconds to choose the correct answer. I would personally monitor for atrial fibrillation. Ivabradine is a hyperpolarization activated cyclic nucleotide gated channel blocker. It's indicated to reduce the risk of hospitalization for worsening heart failure in patients with stable symptomatic chronic heart failure with a left ventricular ejection fraction of less than 35, who are in sinus rhythm with a resting heart rate of above 70 beats per minute and either are on maximally tolerated doses of beta blockers or have an indication to beta blocker use. And it's usually taken orally twice daily. Now, patients should be monitored for AFib and bradycardia when on procorolan, especially in the very first days of initiating therapy. Now, the most common adverse reaction when using this drug include bradycardia, hypertension, AFib, and what we call the luminous phenomena. Those are just by the way. Let's move to the next slide, please. ASM is a 67-year-old man who presents to the cardiac clinic for hyperlipidemia management with a past medical history of type 2 diabetes mellitus, which was diagnosed 11 years ago, and a neuropathy that has been as a result of the diabetes mellitus. He currently takes a gram of metformin after breakfast and after dinner, then 10 milligrams of glipizide, also for the management of diabetes, twice a day. And because of the neuropathy, he was put on 300 milligrams of pregabalin, taken orally twice a day. Now for his lipids, he takes high-intensity statin, rosuvastatin, 40 milligrams at bedtime. His fasting labs include a total cholesterol of 251, TG of 520, HDL of 30, and an LDL of 68 milligrams per deciliter. He informs you that he has made several lifestyle changes in the past 1 year. His type 2 diabetes is well controlled, and the A1C stands at 66.7%. Now, this gentleman follows a healthy heart diet. He doesn't smoke, he doesn't use tobacco, he doesn't drink alcohol. So my question to you is, which of the recommendations listed below would you make to ASM's regimen? Would you continue rosuvastatin and encourage lifestyle changes, or would you stop rosuvastatin and start or initiate high-intensity atorvastatin at a dose of 80 milligrams at bedtime? Or would you stop rosuvastatin and initiate fenofibrate? Or would you initiate icosapent ethyl, what we also call Vascepa, at a dose of 2 grams orally twice daily? I'll give you 10 seconds to choose the correct answer. So D would be our best bet. I would introduce icosapent ethyl or Vascepa at a dose of 2 grams twice a day. Now, as per the ESC and the EAS dyslipidemia guidelines, these are European guidelines, initiating icosapent ethyl at a dose of 2 grams twice daily would be the correct choice. This patient is already on an appropriate intensity statin but still has elevated TG levels. Now the reduce-it REDUCE-IT trial demonstrated in patients with hypertriglyceridemia and established cardiovascular disease or diabetes mellitus with other risk factors on statin therapy that high-dose icosapent ethyl significantly reduced risk of ischemic events, including cardiovascular death. Now, rosuvastatin 40 milligrams and atorvastatin 80 milligrams at bedtime are both high-intensity statin therapies, and minimal differences will be seen in TG lowering if you switched from rosuvastatin 40 to atorvastatin 80. So I wouldn't opt for that option. Then replacing rosuvastatin with fenofibrate, option C, wouldn't be correct in my opinion, because statin therapy is recommended as first line drug choice for the prevention of primary ASCVD events in patients with diabetes mellitus. Now, statin therapy is first drug of choice to reduce cardiovascular risk in high-risk individuals with TG levels exceeding 200 according to guidelines. Therefore, stopping rosuvastatin wouldn't be the best choice. Now, when the TG levels are above 1,000, patients are at an increased risk of pancreatitis, and that's the moment when you need to consider using fenofibrate. So C isn't a good option at the moment either. Now, continuing rosuvastatin with the lifestyle changes wouldn't be appropriate because his TG remains elevated despite lifestyle modifications, which we are told he has already made. By the way, he follows a healthy heart, or a heart healthy rather, lifestyle. He doesn't drink alcohol, and his type 2 diabetes mellitus is well managed. It is at goal according to the details we've been given. Now, since his TG levels remain above 500 milligrams per deciliter, medication changes are appropriate. We cannot just bank on a lifestyle alone. Now, icosapent ethyl inhibits hepatic secretion of TG, and it also promotes metabolism of the same. So it would really add value to the current regimen. So I would settle for answer D as our best bet. Let's move to the next question, which reads, QTP is a white man who presents to the cardiac clinic for follow-up. He has a past medical history of chronic kidney disease, hypertension, and he also has ACC-AHA stage A heart failure. Today he has a systolic blood pressure of 143, diastolic 88, with a heart rate of 57. He currently takes 10 milligrams of Ramipril orally once a day with 150 milligrams of losartan once a day. He doesn't report any symptoms of fluid retention, and his potassium as we speak is 4.7 milliequivalents per liter. He has a creatinine clearance of 55. So my question to you is, which of the therapeutic plans listed below would be the best for Mr. QTP? Would you initiate Amlodipine? Is it true that no changes are necessary? Would you initiate Spironolactone, or would you initiate isosorbide dinitrate? I'll give you 10 seconds to choose the correct answer. Personally, I would add Spironolactone to his regimen. Now, according to the ACC, AHA, and the Heart Failure Society of America Heart Failure Guidelines, goal BP in patients with stage A heart failure is less than 130 systolic, 80 diastolic. Now, QTP is currently above goal, and additional blood pressure control would lower the risk of adverse cardiovascular events. Now, preferred agents include an S inhibitor, mineralocorticoid receptor antagonist, and possibly the fixed dose combination of valsartan, sacubitril. In my opinion, Spironolactone would be the best one from that list. Now, the use of nitrates in stage A heart failure for blood pressure lowering isn't the best choice because of the side effects that would ensue. Now, there is limited evidence to support the use of amlodipine as part of an antihypertensive regimen in patients with heart failure. So I would be biased towards the use of Spironolactone, and I would not offer to leave things as they are, because we need to improve his quality of life. Let's move to the next slide, which reads, MWG is a 55-year-old black man who reports to the cardiac clinic for a routine follow-up. He has a past medical history of type 2 diabetes, mellitus, he's obese, and he has a compensated heart failure. Ejection fraction is 35%. He has dyslipidemia and hypertension. Now, during today's visit, his blood pressure is 148/80. 4 weeks ago, it was 152/92. And 12 weeks ago, it was 166/86. His pulse was is 82 today. It was 86 4 weeks ago, and it was 84 when you first saw him 12 weeks ago. The weight has soared a little bit. Today it's 156. He's done fairly well. 4 weeks ago it was 160, and when he was first seen it was 158. He is currently taking 100 milligrams of losartan orally once a day. He administers insulin glargine as his basal insulin at a dose of 30 units at bedtime, and his bolus is insulin aspart, which he administers 10 units before each meal. He also takes 20 milligrams of furosemide orally once a day and 10 milligrams of Simvastatin at bedtime. So those are his labs. There is no edema noted. Lab works are within accepted limits. So considering them as they are, my question to you is, which of the medications listed below would be the most appropriate to add to MWG's regimen? Would you consider adding lisinopril, amlodipine, hydralazine, or carvedilol? I'll give you 10 seconds to choose the correct answer. I would opt for carvedilol. Now, our patient's goal BP should be below 130 systolic, 80 diastolic. Further intervention in terms of hypertension is needed in my opinion, because we are told blood pressure is still above goal. 148/88 is way above target. She has systolic heart failure and isn't currently on any beta blocker, which is a mainstay of therapy. Now her heart rate is well above the desired upper 50s or lower 60s goal. Remember, we were told it is 82 today, so we have room for maneuver. And the only appropriate option, in my opinion, is carvedilol, which will have to be added at a lower dose and slowly titrated due to the heart failure that this patient suffers from. So I would opt for answer D and reject the other three. And just like to remind you that hydralazine coupled with isosorbide dinitrate could be important addition moving forward for this patient's treatment. And subsequent improvement in our BP by default would occur if we added this, given data supporting, especially in the black race, there is additive benefit. But beta blockers, in my opinion, are still the first line when it comes to a patient in this category. Now, adding lisinopril doesn't make therapeutic sense. We are told the patient's already on an ARB, losartan, so I wouldn't opt for answer A. Then amlodipine can be used in the future if need be for further BP control, but at the moment carvedilol would be our first choice to introduce. So let's move to the next question, which reads, which of the antiplatelet agents listed below has a contraindication in patients with a history of stroke or TIA? Is it the combination of prasugrel, vorapagza, or is it prasugrel and ticagrelor, or is it clopidogrel and ticagrelor, or is it clopidogrel and prasugrel? I'll give you 10 seconds to choose the correct answer. So I would settle for alternative A. Now, prasugrel is contraindicated in patients with a history of stroke or TIA because patients on it had, in a study, a higher incidence of stroke. Vorapagza is contraindicated in patients with a history of stroke, TIA, and intracranial hemorrhage because of an increased risk of intracranial hemorrhage. Now, clopidogrel and ticagrelor don't have contraindications in patients with a history of stroke or TIA. So A would be the correct answer in this case. Let's move to the next slide. D.T.M is a patient with newly diagnosed angina and he has been initiated on nitroglycerin patches. So my question to you is, which of the strategies listed below would be the best to avert the development of nitrate tolerance in this patient's case as we initiate the patches? Would you advise the patient not to remove the patches at all? Or would you advise the patient only to use the patches for 12 hours and then have a 12-hour patch-free period? Or would you advise the patient to only use the patches for 24 hours and then have a 12-hour patch-free period? Or would you advise them to administer the patches and leave them for 7 days before removal and change? I'll give you 10 seconds to choose the correct answer. Alternative B is the correct one in my opinion. Studies reveal that tolerance develops within 24 hours of use of these patches. Now, it is recommended to use each patch for 12 to 14 hours and then to have a nitrate-free or patch-free period of 10 to 12 hours. That makes alternative B the most appropriate. Now, according to the ACC and AHA chronic stable angina guidelines, the mechanism of development of tolerance is unclear. Now, there have been many theories that have been proposed, such as the decreased availability of sulfhydryl radicals, activation of the RAS, an increase in the intravascular volume due to an altered transvascular Starling gradient. Others feel generation of free radicals with enhanced degradation of nitric oxide may be the reason behind the development of this tolerance. So those are just by the way. The mechanism is still not clear. Those are just theories to try and explain why things happen the way they do. Let's move to the next question. So, HPB, a patient with a history of poorly controlled hypertension, presents to the hospital. He only takes 100 milligrams of labetalol twice daily orally to manage his hypertension. He is in need of further blood pressure lowering. Now, the lab works today include sodiums of 138, potassium of 3.3, BUN there of 14, glucose at 88, and the others are as they are. My question to you is, which of the drugs listed below should be avoided based on the information provided? Will you avoid the combination of hydrochlorothiazide and triamterene? Would you avoid chlorthalidone? Would you avoid spironolactone? Or would you avoid lisinopril? I'll give you 10 seconds to choose the correct answer. So I will settle for chlorthalidone. Now, the patient's potassium levels are on the low end of normal. If I remember well, they stand at 3.3 milliequivalents per liter. Using chlorthalidone would run the risk of causing worsening hypokalemia. Remember, it's potassium wasting, and we're already at 3.3. The range is usually 3.5 to 5.5, so we'll be trading in a very dangerous zone. We'd end up with an arrhythmia if we administered chlorthalidone. Now, the other three options all have potassium sparing properties and would be preferred compared to chlorthalidone. Lisinopril or the combination of hydrochlorothiazide triamterene would be higher on the preferred list of agents, with spironolactone generally reserved for patients with resistant hypertension or primary hyperaldosteronism. So those are just explanations as a by the way. So my highly esteemed and treasured listeners and viewers, that brings us to the end of part 27 of our pharmacotherapy MCQ series. I'm very thankful you sacrificed and made time to listen to me and to watch this video. Now, if this video helped in any way, I would like to urge you to give it a thumbs up and to like it and to share it widely with your colleagues. And if you haven't yet done so, I would like to urge you to subscribe to my YouTube channel. And I would like to promise you that the best is yet to come. I look forward to interacting with you in part 28 of our Pharmacotherapy MCQ series. Thank you for always being there for me.